good evening, everybody. So today we have with us three faculties. First of all, I would like to introduce Dr. Richard Smith. He practiced as a doctor in Scotland and New Zealand, and in 1979 he joined PMJ, and he was editor-in-chief from 1991 to 2004. Then he served as a chief executive of PMJ Publishing Group and United Health Europe, and was the director of United Health Chronic Disease Initiative to combat chronic disease in low and middle income countries. And then for 6 years, till November 2018, he was the chair of Board of Trustees of International Center for Diarrheal Disease, Bangladesh. He is also the chair of Patients Know Best, a company that gathers together all medical and social care records of patients and puts them under control of patients. The UK Health Alliance on Climate Change and Open Farm. And he is also an adjunct professor at Imperial College Institute of Global Health Innovation and a founder of fellow of the Academy of Medical Sciences. And he is well known for his work on death and dying. And he also chairs the Lancet Commission on Value of Death. He worked on 2018 report from Royal College of Physicians on medical professionalism. And his areas of interest are end-of-life care, public health, scientific publishing, and health in developing world. And Dr. Richard joined the Point of Care Foundation board in 2019, succeeding Sir Adrian Monday as the chair. So I welcome you, Dr. Richards. Then next, I would like to welcome Dr. Farzana Khan. Dr. Farzana is a palliative care physician as well as a researcher from Bangladesh. She did her MBBS in 1994, and then she did her master's in public health. Then MA in palliative care from Lancaster University, UK. She is the fellow of International Pain Policy Fellowship at Wisconsin University, USA, and she has completed her fellowship in palliative medicine from Institute of Palliative Medicine, Kerala, and she is pursuing PhD in global health from University of Edinburgh, USA. Now, she is also the executive director of Faizuddin Khan Research Foundation, and it's a local non-profit organization based in Dhaka, which provides palliative care in vulnerable contexts like urban slums, refugees camps, etc. And she was working as the advocacy ambassador of palliative care for Bangladesh. She is an affiliated member of Respire, University of Edinburgh. So welcome, Dr. Farzana Khan. And now I would like to welcome Joan Marston. And we all know her because she already took one session for us. But for a formal introduction, she has nursing and social background and has been active in hospice and palliative care for 33 years at local, national, and international levels, especially for in the field of children's palliative care. And on retirement as CEO of the International Children's Palliative Care Network, in 2017, she established Palliative Care in Humanitarian Aid Situations and Emergencies, which is now part of the Global Health Academy of University of Edinburgh. She is on the executive committee of Palliative with special responsibility for advocacy, and she is also the global ambassador for ICPCN. And over the years, she have contributed to numerous publications, WHO working groups, global advocacy initiative, teaching, research, and conference. And her special interest is in spirituality in children with palliative care needs. Welcome, John. And now I would like to invite Dr. Richard Smith for his presentation on climate change and health. It's over to you, Dr. Richard Smith.
Dr. Richard,
You are muted.
Sorry, after all that, I'm sorry. It's very good to be here, and it's funny. I spend my life telling people don't get off mute, and now I've gone and done it myself. So I'm trying to share my screen, and I share it with all participants. So if I go ahead, so I think it's only the host can share the screen. So can I have access to share it, Sri?
Yeah.
Yes, sir. You already have the access. In case
Do
you
I?
want us to share.
Okay, let me try. It's asking me who can start sharing when someone else is sharing. So I click on all participants. Maybe it'll be all right now. No, it doesn't seem to be working.
Okay, just give me a moment.
Okay. Good. Well, while you're doing that, maybe I could say it's, I feel as if I've been in Kerala for the last few months because I've been reading a new novel that's about to be published by Abraham Verghese, which is called The Covenant of Water, and it's set in Kerala from about 1900 to about 1970, and his family comes from Kerala, and it really created the feel of Kerala magnificently. I'm still having problems here. If I click on host only, or you're the host, aren't you? Oh, there it is. Is that's you putting it up, is it? Not me?
Yes, I am putting it up.
Okay, well, should we do it like that then? So so I'll have to ask you to share the screen to move on to the next slide.
Yeah, yes. Once you instruct, I will move on to the next slide. Hope that will be
Okay.
fine.
And can you make it the whole screen? Not just the...
Hope it is visible now and clear.
There we are. Good. Okay, so as you heard, the relevant function for this talk is that I'm the chair of the UK Health Alliance on Climate Change, and in a minute I'll tell you what that is. So the next slide, please. Next slide. So this is a slide that really every one of us should have burnt into our brains. This is emissions of greenhouse gases from 1750 to 2021, and I hope you're all familiar with this. And you can see that it began to take off in about 1900 and has increased exponentially. I mean, I was born in 1952, and you can see there's been a huge increase then. We're throwing out 35 billion tons of carbon dioxide equivalent every year. And this is happening because of industrialization all around the world. If we go to the next slide, and one of the things this has led to is a global increase in temperature. The average increase is now somewhere between 1.2 degrees and 1.3 degrees compared with pre-industrial levels. Already we're seeing the effects of climate change very seriously. You saw how a third of Pakistan was flooded last year. There are wildfires everywhere. There are huge storms, which I think you've probably experienced in your part of the world. So this is beginning to happen. I think sometimes people get a bit confused and think, well, if the temperature just goes up by 1.5 degrees, surely that doesn't mean very much, because on the average day, if the temperature was 1.5 degrees hotter, it wouldn't really mean very much. But of course, we're talking about the climate here, not the weather. And the climate is what you expect. The weather is what you get. And an increase of 1.5 degrees means much more extreme changes in temperature and in other climatic effects. So the next slide, please. And this sort of shows the fundamental problem we are wrestling with. So if everybody in the world live as people live in North America, with high levels of consumption, with air conditioning, with big cars, we would need 5 planets. Now, everyone on this call will know that we don't have 5 planets. We have only 1 planet. If everybody in the world lived as we live in Western Europe, we would need 3 planets. The only people in the world who are living in a sustainable way are people in the Asia-Pacific region and in Africa. And that's certainly not all of the people in the Asia-Pacific and Africa region. And of course, it's because most people are poor, Many people don't even have access to electricity or any kind of energy source. They consume very little. Now, the problem is that poor people want to move in the direction of those in North America. And clearly that must be allowed to happen to some degree. You can't expect people to continue to live in poverty, severe poverty all their lives. But at the same time, we cannot live as people live in North America. So what it means is the people in North America, the people here in Britain, where I am, we must drastically reduce the greenhouse gas emissions we produce and allow the people in poorer areas to have more energy. Although, of course, ideally, they will not have energy that comes from fossil fuels, but from renewables. And this is the problem, really, that arises each year at the COP meetings, the annual UN meeting on climate change, that the rich people are reluctant to give up their lifestyle. The poorer people understandably want to adopt that kind of lifestyle. And there's a tremendous tension that is manifest at every meeting. Right, the next slide, please. This is to show that increasing greenhouse gases in the atmosphere and raising the global temperature is by no means our whole problem. All parts of our environment are affected. I mean, here in Britain, we have the most denatured country in the world. There's been dramatic drops in species of wild animals and plants and insects. Our soil is severely depleted. The oceans are poisoned. So even if tomorrow we were to hear that global warming is no longer a threat, we still have a very, very serious problem. We're destroying the world that we're living in. Next slide, please. And this sort of shows where we've got to in Britain. So here in Britain, we have a legal commitment to get to net zero, meaning that that any greenhouse gases that we might emit, we will offset in some ways by planting more trees or embedding it in peat bogs or using perhaps some kind of technology that doesn't yet exist. So we are legally committed to doing this. And in order to do that, we need to follow this green line at the bottom in order to avoid going above 1.5. But what is actually happening is that red line at the top. So there has been some reduction, but we're not anywhere like on track, even though we have a legal commitment to do this. And there are two gaps, really. One is the delivery gap. It's rather easy to say, we will be net zero by 2050, but it's much more difficult to actually make it happen. That's a really complicated, difficult problem. So there's a delivery gap, but there's also an ambition gap that actually the targets we've set ourselves are not adequate to stay below 1.5. And this is a country where it is taken pretty seriously, but there are many countries in the world for all sorts of reasons where climate change is not taken so seriously. Next slide, please. And the tragedy is that we need really to be steadily reducing greenhouse gas emissions by 7% a year, but in fact, they're increasing year on year. Last year's emissions were higher than ever before. And I hope you'll have been aware that on Monday of this week, the Intergovernmental Panel on Climate Change, a collection of scientists and politicians said, you know, we are not on track at all to avoid the temperature going above 1.5. And if it goes much higher than that, we face very, very serious problems. Even at 1.5, we face serious problems, but they become exponentially worse as the temperature goes up. And at the moment, we're headed for an increase of something like 3 to 4 degrees, which will have the most catastrophic effects, drowning lots of small islands, drowning lots of coastal communities like in Kerala, unfortunately, drowning London, drowning Shanghai, drowning New York. So next slide, please. And who was it that produced these greenhouse gases? I hope you've seen these world mapper maps that distort the world in relation to whatever it is you're looking at. You can see that North America is huge. You can see there's that very big island off the coast of Europe, which is Britain. We were the first country to have the Industrial Revolution, so we've produced a huge proportion of greenhouse gases. But if you look at Africa, you can hardly see it. You can see South Africa, but you can't see the rest of the continent. If we go to, so that's who produced the gases, who's suffering the harm. The next slide, please. And it's largely the reverse of just what we've seen. So the big harm is going to be in Africa. It's going to be in India, where many of you are now. It's going to be in the Middle East. So there's a huge disjunction between who created the problem and who's going to suffer the most. So this is an issue of global justice. Next slide, please. And how does this planetary crisis affect health? Well, air pollution, which is closely related. I mean, we've had air pollution for much longer than we've had serious climate change, but it has exactly the same roots as climate change. And it's killing 7 to 8 to 9 million people a year all over the world. I mean, I know that India has very severe air pollution problems. We do here in London. There are storms, which many parts of the world have experienced. There are floods and wildfires, heat waves, which was a severe heat wave in Pakistan and South Asia last year. There's damage to mental health, and that is already happening. I mean, all of these things are already happening, but they're going to get rapidly worse. And there's extension of infectious disease. So malaria will begin to spread to new areas as temperatures increase, and dengue. And then, of course, pandemics have exactly the same roots as climate change and environmental destruction, as wild animals and humans are forced into ever closer contact as forests are destroyed. But the way that it will really affect people is there will be food shortages. I mean, these are already being experienced, I know, in Bangladesh, causing people to migrate to Dhaka and potentially to other countries. There's going to be water shortages. There was a report just last week saying that some huge proportion of the world is going to be short of water in about 10 years' time. And there will be forced migration, which again, we're seeing already, but potentially billions are going to find themselves living in places that will become uninhabitable. And sadly, I think the way all this may play out as people fight over water, food, and territory is with war. Next slide, please. And this is a sort of relating what's happening to the planet to what happens to individual patients. So at 37 degrees, you're pretty healthy. As it goes up to 39, you get sick. As it goes up to 4, you become in mortal danger. And at 5 degrees, it's just too late. And like I say, at the moment, we're headed for something like 3 to 4 degree increase, but we're still not managing to reduce emissions of greenhouse gases. Next slide, please. But here's the sort of good news after lots of bad news. If we were to make the changes that we need to make in order to respond to climate change, then there would be a lot of benefits for health. I mean, unsurprisingly, what's good for the planet is also good for us as individuals. So if our homes were much more energy efficient, I don't think there's a particular problem in Kerala, but it is here where it can get very cold, then it means the homes are cheaper to eat, and it improves physical and mental health. Eating local plant-based diets rather than more meat, so assuming a diet that's largely vegetables, not much meat, is good for the planet. It's also good for physical and mental health. Walking and exercising more instead of driving, walking and cycling is good for cardiovascular health and for mental health. Access to green and blue spaces, perhaps not a problem in Kerala, but a serious problem in many cities in the world where people have almost no access to green and blue spaces. But again, it improves physical and mental health. And then community building is also good for the planet, good for people's health. So that's, I think, an important message to remember. And it's why potentially health professionals can be so important with this issue, because we have a message, health is being seriously harmed, but if we make the changes we need to make, there will be real benefits. Next slide, please. So how should we respond? Next slide, please. Well, I don't know how many of you have seen this Netflix movie that has a lot of A-list Hollywood stars in it. It's called Don't Look Up, and it imagines a scene where some scientists, that's there on the right-hand side, have identified a planet that's about to collide with Earth and completely destroy it. And they try to get the attention of the media, those two people on the left, of a chatty kind of breakfast television program, and they try to get the attention of politicians, and they just fail until eventually people do look up and they see the planet heading towards Earth is no distance away whatsoever, and it crashes into the Earth. Most people are destroyed. Meanwhile, the rich people in the world, the people who own Facebook and Amazon and Google, have got in a spacecraft and headed off to another planet. But that's not an option for most of us, and it's a hell of a long way to another planet. So I urge you to watch this. It's actually very funny as well as very provocative. Next slide, please. But how should we respond? Well, I hope most of you have heard the message that I'm delivering before, and it can potentially feel, oh my goodness, you know, we're doomed. There's nothing we can do. It doesn't matter. So we avoid it. We forget about it. We don't think about it. We lapse into anxiety and despair. We feel helpless. We're complacent. That is not the way to go. I mean, the reality is that something needs to be done. We have to recognize that each of us can make a difference. It may be something very small, not driving your car one day, but walking or cycling to work, or changing your diet, or writing to your MP. There are things everybody can do. And a lot of those things make you feel good. And actually action leads towards more action. It also brings you into contact with others, and you can feel empowered, hopeful, you can have a purpose. So that's the message I want to give you. That's the way to respond. Next slide, please. And this is a group we have here in this country. We have a group called Extinction Rebellion, which have been very active in protesting. These are a group of doctors, many of whom I know, sitting outside Downing Street saying, you know, we must get rid of fossil fuels. We've really got to act on this issue. We've been far too slow. We've got to take it much more seriously. Next slide, please. And as I said, I'm the chair of the UK Health Alliance on Climate Change, which brings together 38 organizations of health professionals in this country. So most of the Royal Colleges of physicians, surgeons, nurses, pharmacists, GPs, lots of specialist societies, the BMA, the BMJ and the Lancet, and altogether our members are about 1.2 million. So it's most of the workforce in Britain. And whereas 10 years ago, it was quite difficult to persuade Royal Colleges to take all this seriously, now they begin to be very serious about it and much more active. And we're working to do all we can to mitigate the crisis, to keep the temperature as low as possible, to avoid the destruction of the environment. But we're also encouraging adaptation because the problems are already here. Something like 10% of the hospitals in Britain are prone to flooding, and it'll rapidly become more. But we're also about promoting the benefits to health. Health professionals, I would say, have not been as prominent in the whole debate about climate change as we should be. I mean, 2 years ago, when it was the 26th of the annual meetings on climate change, the COP meetings, there was some discussion of health, but that was the first time it had been discussed. And it wasn't discussed at the Egypt meeting last year to the same degree. So health professionals, we need to speak up on this. Next slide, please. And we need a response at every single level, globally, nationally, regionally, within our cities and regions, the health system, and I'm going to talk more about that briefly, and that includes end-of-life care. And as individuals, we must change. Everything has got to change if we're going to overcome this crisis. Next slide, please. So let me talk a little bit about the health system itself, because I think sometimes people have been slow to recognize that the health system is itself part of the problem and it's going to have to change. So globally, if healthcare were a country, it would be the 5th largest emitter on the planet, which might seem a bit surprising when you first think about it. But actually, when you think of all the activity that goes on in the health systems, all the people that are employed, it's not so surprising. And the US health system accounts for about 12% of US emissions. And when you think that the US health system is something like 20% of the economy, again, that's not so surprising. And if you think back to the slide where I showed how people in North America are living in a way that would mean we would need 5 planets, that is a huge amount of emissions. And in fact, the US health system is probably something like half of all the emissions from healthcare systems. In the NHS here in Britain, it's about 5% of carbon emissions. And 1 in 20 vehicles on the road is related to the NHS, which again is a bit surprising when you first hear it. But when you stop to think that the NHS in Britain employs about 1.4 million people, it's not so surprising. Next slide, please. But what is happening with the carbon emissions of healthcare systems? Well, unfortunately, they're almost all going up. So here we are with the world's major threat to health, as agreed by WHO and the Lancet. And what's happening with health systems? Well, their emissions are going up. And clearly that's unsatisfactory. They're going to have to get to net zero like everybody else. So next slide, please. And actually, the NHS in England, I mean, I'm not one to boast about the NHS being the world's best health system. It absolutely isn't, although it does have things that are good about it. The fact that everybody can access it, they don't have to pay when they access it, although there are awful problems at the moment with accessing it. Well, the NHS in England is committed to getting to net zero on everything it directly controls by 2040, and by 2045 for everything it consumes, much of which are things that come from outside the country. It's the only system in the world that has high-level commitment from the board of NHS England. It has a chief sustainability officer, an Australian doctor, Nick Watts. It has a plan, it has funding, and it has reporting every year of how things are going. There's no other health system in the world that has that, and it doesn't apply in the other 3 NHSs in Britain. As you're perhaps aware, we have 4 NHSs, 1 in England, by far the biggest, 1 in Scotland, 1 in Wales, and 1 in Northern Ireland. And they do not have the same level of activity and commitment that the NHS in England has. But this is the carbon footprint of the NHS, and it would be similar, I suspect, for most health systems. And one thing to notice is that about 2/3 of it is things that are procured, the equipment, the drugs, the food, the ambulances. And up there, the single biggest component is drugs. And when you think that half the drugs taken in the average health system are never actually taken, that's a tremendous waste. And a lot of those drugs, as you know, are given at the end of life. A particular thing is inhalers, asthma inhalers. Some of them are extremely bad for the environment, whereas if you switch to dry powder inhalers, it's much, much better. Anesthetic gases are a particular problem. And if you look here on the right, you can see that most of the emissions, unsurprisingly, are coming from hospitals. They're not coming from primary care, and they're not coming from hospices and community services. Next slide, please. And this is a summary of the plan to get the NHS to net zero. And I'll just prick out something. So there are many, many different interventions are needed. It's not just a matter of changing the light bulbs, changing the electricity supply. Everything's got to change, including clinical activity. A lot of the plan depends on preventing disease so that people don't have to go into the health system, and reducing inequalities. And sadly, we've been talking about that in Britain for 50 years and made little or no progress. Anesthetic gases and inhalers are a particular issue, as I've said. I mean, moving to doing lots of things digitally rather than face-to-face has the potential to reduce things quite dramatically. If I had flown to Kerala to give this talk, then my carbon footprint would be huge. But as I'm doing it online from my basement in London, it's not so carbon intensive. There's going to need to be a lot of research, a lot of innovation. Nobody really knows what a net zero health system looks like. So we've got to work a lot to find out what it might look like. There will have to be some sequestering. It's not going to be possible to get to absolute zero. And sequestering carbon, finding a way to offset it is very difficult. And obviously, as 2/3 of the footprint is procurement, we'll have to work with suppliers. Next slide, please. So I just wanted to end with a couple of slides talking particularly about end-of-life care and the planetary crisis. Next slide, please. Well, this shows what happens with costs and activity in the NHS in the last year of life. So you can see there's a huge increase in hospital admissions, GP attendances, emergency room attendances in the last 3 months of life, and particularly in the last 2 to 1 month. And I think there's no doubt that certainly in Britain, a lot of that activity is misplaced, that actually people could have a much better end of life experience and the costs could be much, much reduced. And it's about 10% of the costs of the NHS go on people being treated in the last year of life. So that's quite a big chunk. And I wanted to emphasize that cost and carbon tend to go together. So that means it's a big carbon footprint. Next slide, please. And something that we emphasized in our Lancet Commission, that I think our unhealthy relationship with death, the way that we're trying to constantly fend it off with expensive treatments and surgery, the planetary crisis that I've been talking about, the pandemic, and antimicrobial resistance, they all really flow from the delusion, and it is a delusion, that we're masters of nature, not part of nature. We are absolutely dependent on nature for our survival. We are not the masters of it, and we've deluded ourselves. Next slide, please. As you're perhaps aware, huge amounts of money are being spent on the explicit pursuit of immortality, on dramatically lengthening life. And I wonder to some extent how much all of medical research is an implicit pursuit of immortality. Next slide, please. Okay, yes. And I just thought, how is it that we live so comfortably, seemingly, with the idea that the planet around us is being rapidly destroyed? And I begin to think it's because we're all used to living with the knowledge of our own death, and somehow we have a way of pushing it to one side, thinking it's never going to happen. As Freud said, the unconscious of every one of us is convinced of his own immortality. And does the fact that we're so used to living with the idea we're going to die and not being disrupted of it also allow us to live with the destruction of the planet? Next slide, please. So what can you do now, right, starting this afternoon or this evening or whatever time it is? You can move better, you can fly less. I will never come to Kerala because I'm never going to fly anymore. You'll drive less, you'll walk and cycle more, you'll eat better, you'll move from a high carbon diet to a low carbon diet, one that's based primarily on vegetables and fruit, and that'll be good for you. You'll buy better, use your money in different ways, divest from fossil fuels, change your bank, invest in renewables, vote better, make sure that when there's any election for your region, your country, your Royal College, that you're thinking about who's going to put climate change at the forefront. You can campaign better, join organizations like the UK Health Alliance or Greenpeace or Friends of the Earth, make political statements, and you can talk better about the problem. Next slide, please. So this is my last slide. And I want to emphasize that it is possible for an individual, every one of you, to make a difference. So this shows what happened in Sweden in terms of number of flights from Stockholm Airport between 2017 and 2020. And you can see that the flights were going up by almost 10% a month compared with the year before, until suddenly at the end of 2018, they began to reduce. Well, what was it that happened? It was that a teenager, a small autistic girl called Greta Thunberg, began to start a one-person protest outside Parliament in Sweden. She went there all alone, sat there every Friday until slowly but surely more and more people, particularly young people, joined her, and people joined all around the world. And those now happens, and I'm sure, I know these protests happen in India, and she has become a leading spokesperson for the whole world, speaking at the COP meetings, speaking at the UN. So one person can make a big difference. That's the end of my talk. Thank you very much for listening. If there are questions later, I'll be delighted to answer them as best I can.
Thank you, Dr. Richard. Now we'll move on to Joan Marston, who will be speaking about climate change, humanitarian crisis, and palliative care. So, Joan, it's over to you.
Thank you so much. And it's so good to be here today with you again. And thank you, Richard, for that brilliant presentation, but it's made me feel rather down and very challenging. So thank you. Thank you, everyone, for letting me be here as part of this fellowship. And so just to start with, a little bit about Palliative. It is a global organization. It's steadily growing. And the idea is we want palliative care to be included as an integral part of the humanitarian response to crises. We're hosted by the Global Health Academy of the University of Edinburgh, and we have 4 active working groups that anyone who's interested is welcome to join Palliative and to join a working group. So we work through advocacy, communication and networking, education and research. And this was really the picture that set us off. This unending stream of Syrian refugees. It just never seemed to stop. Every time you opened your television, turned it on, you saw this. And so I sent out a question, what is happening about palliative care in this sort of humanitarian crisis? And the answer that came back was very little. And that was really the impetus. The suffering of so many people led to the development of Palliative. And so we were asking questions like, what is the value of death in the face of war? How do we grapple with the uncertainty of living with the sacredness of death and dying is invaded? What do we do when both health and death systems begin breaking down? And what steps must we take to preserve, promote, and protect human dignity and ameliorate suffering, which are absolutely the essential parts of palliative care, as both a priority and an obligation, as life is stolen and death is perpetrated. And it's not just war, it's all those other causes of humanitarian crisis. And both Raj and I were part of that commentary. And so we have a very democratic leadership group. We are an executive committee. There's no chair, there's no CEO. And we're people from different parts of the world with different interests. Some of us are more interested or have a special focus on children, others on the spiritual side. But we get together on a very regular basis and we work with our working groups to really get Palliative going. We have quarterly education series and webinars, and our next one is next month, and you're all welcome to join that webinar. We have it on 2 days so that we cover all the times across the world and the different time zones as well. So what we're going to look at today very briefly, because this is a huge field, is what is palliative care in a humanitarian crisis? What are some of the interventions? And how do we plan for the future? Because as we've seen from Richard's presentation, the future indeed can be very bleak. And if we believe in universal health coverage and that palliative care must be part of every health system and reach every person who needs it, it has to be available in a humanitarian crisis, because we live in an age of really increasing complex humanitarian emergencies. We just have to look at the world around us, the ongoing wars in so many places, in Yemen, the troubles in Afghanistan, across Africa, and of course, what we're seeing in Ukraine, and more recently, the earthquake in Turkey and Syria. So what is a humanitarian emergency? It's an event or a series of events that represent a critical threat to so much, to health, to safety, to security or well-being of a community or other large group of people, usually over a wide area and often crossing borders across countries. And humanitarianism will recognize this is so close to palliative care, the benevolent response to the suffering and the needs of others. That's what we do. It is action. It's not just talk. It's not pallilalia, it's palliaction, to prevent and alleviate human suffering wherever it may be found, to protect life, quality of life and health, and to ensure respect for the human being. That when we come into this field, we have to recognize that in an acute humanitarian crisis, the saving of lives is always the priority. So when we come in, we have to respect that. We have to be humble, know our place, and know where we fit into the response to the humanitarian crises around the world. A term that's often used these days is fragile, conflict-affected, and vulnerable settings. And often these occur in countries with already very fragile national health systems, with a lot of poverty, a lot of internally displaced persons, and we see with these crises an increased burden of suffering, of loss, of so much trauma, of diseases and increasing diseases and infectious diseases, and of course an increase in mortality and in death. And one conflict and one crisis can lead to other crises. So if we just look at something like the war in Ukraine, which started as a conflict crisis, and we see the destruction, which has led to migration, internally migration, a huge number of refugees leaving the country, the impact on other countries, the public health crises, the infections that you get when there is a climate crisis. If we look at Malawi now with Typhoon Freddy, cholera is increasing, and that is going to increase in Mozambique and in Madagascar as well, because the environment is destroyed. The habitat for humans and animals, there's this changes in the lifestyle. And of course, water resources are affected. It's not just about electricity, it's also the water resources, which leads to these infections. And if we look across the world at the numbers who are in need of humanitarian aid, it is 1 in every 23 persons on the planet. 75% are women and children, and 115 million are displaced. So how do we provide palliative care when already our resources for palliative care, already our numbers providing palliative care are far too little to actually meet the needs in a country where there's reasonable stability, where we're not facing a huge humanitarian crisis? And we look at this and we see 86% are in low and middle income countries. So how do we do it? And of course, the only way we can do it is to educate, to integrate, to work together, to collaborate, and to advocate that it is in every country's health system, and it is part of universal health coverage. We've heard about the natural disasters, so I'm not going to say anything more about that, but these can lead to epidemics and plagues. We have the man-made emergencies, like the conflict situations, and then things like crashes, fires, industrial accidents. And we're all sitting and worrying and anxiety about a nuclear accident happening. And then we have these complex emergencies, which might start off as one, which then integrate all the different types of emergencies. And then I think the one that we see in Africa and India so much, where people live in sustained extreme poverty, which makes them vulnerable to all types of diseases, to abuse, to conflict. So why is palliative care needed in these humanitarian crises? Well, that's quite easy to see. There's increased mortality. So our end of life care, and that's where we need to look at things like green burials, the number of traumatic injuries and the pain that comes with that, the destruction and the loss that people experience. And we're finding with Ukraine that the majority of the work that is needed there is actually around emotional support, around spiritual care. The breakdown in supply chains, which means that somebody who has a chronic disease can no longer get their treatment, can no longer get their medications. And as I've said, the emotional and the spiritual, not just pain, it's absolute agony that people are experiencing in all of these humanitarian crises. Look at the pictures that are coming out of Turkey and out of Syria, out of Yemen. And this then leads to mass displacement internally and across borders. So our numbers of refugees are absolutely climbing exponentially. And something we often forget about is that in a humanitarian crisis, there's an increase, sometimes even more than 50% of births are premature and complex. And this means we actually have to put a focus on neonatal palliative care. But many of these births are not in hospital. The hospitals are being destroyed by war, by earthquakes. So our resources to care for these tiny, vulnerable prems are really, really limited or totally destroyed. And it leads to ethical dilemmas. And I will never forget when I was in Turkey and working with SAMS and hearing an obstetrician who was the last obstetrician in Idlib. And she was working in an underground hospital with the bombs falling, and two women came in who both needed a cesarean section, and she knew she could only deal with one, and she had to make an immediate choice as to which mother and baby would have to live. And so you have to make these ethical decisions very quickly. So why do we do it? We do it, as we've said, to prevent and relieve the human suffering that comes along with it. To provide palliative care, it's not either life-saving care or palliative care, it is both, can go alongside, and both are important. To provide that pain and symptom control as both an ethical and a medical imperative, but still to continue to regard dying as a normal process and never to intentionally hasten nor postpone death. And then to support the bereaved and to respect the cultural and the religious burial practices, which are so often not possible. And what about all those people who are buried underneath buildings with the earthquakes, with the floods, with the wars across the world? So critical issues we have to look at is access. Can we get there? How do we get there? Do we get there as a palliative care team, or do we get there as part of a humanitarian response team? Or ideally, if palliative care is across your country as part of the country's health system response. We have to think about safety because it is dangerous. How do we communicate when everything is broken down and provide care when resources are so difficult to get? And do people have the knowledge? And in these situations, do we ever think about how staff need support? So we have to collaborate and we have to be part of the coordination when we look at a humanitarian crisis. Because if it's not integrated into both the health system of the country and into the health responders' response, we're not going to have palliative care there. We have to recognize that saving lives in the beginning will always be the priority. So in a complex crisis where the country does not cope, then the Office for the Coordination of Humanitarian Affairs comes in, and the coordination is absolutely Amazing. When you work in these systems, WHO will lead on health. Health hubs are set up, and we need to be part of these health hubs. And we have to recognize that in these crises where people need food, they need shelter, they need water, they need to be made safe, palliative care will be seen as a low priority. So we have to be there to provide it. And who requires palliative care in these settings? Well, of course, those who've got pre-existing conditions requiring palliative care. Those who will need palliative care because they do not have access to their treatment. That person who's on dialysis, who can't get dialysis. And then, of course, the other group is the conditions that are generated by the setting. So we have the trauma, we have the severe malnutrition because they can't have access to food, the injuries and the burns, the infections, and of course, the poor mental health. And that huge, enormous number of people who are the bereaved, who are suffering loss and who are anticipating loss. So who could provide palliative care there? The country's own health services would be the ideal to start with. The humanitarian response agencies. And of course, there's a lot of advocacy going on. Dr. Rajgopal and Palliative India, WHPCA, Stephen Connor, Catherine Pettis from IAHPC, Julia Downing from ICPCN, trying to get it into the global health response. We're trying to focus on humanitarian response agencies and faith organizations at this present time, because we're finding our feet. We are a limited number. We don't have funding. We do it all with our own funding. But also, if we look at the World Health and Palliative Care Day that's coming up, looking at compassionate communities together for palliative care, these are all groups who could provide palliative care. But I think we need to remember the better the integration, the support and the extent of palliative care in a country, the more likely it is that people in a humanitarian crisis will receive it. So if we look at the floods in Kerala, where the palliative care groups were part of the response, if we look at Malawi at present, where there is palliative care across the country and the National Association is trying to provide some palliative care. If we look at Ukraine, which despite the war, because that country had palliative care across the country, supported and financed by government, there is still palliative care. It changes and people have to move, and patients have moved out of danger areas, out of the country, but there is still palliative care. Where there is very little palliative care, the chances of getting it in a humanitarian crisis are almost non-existent. And so where we look at with the response agencies, we look at the triage, because that is very important with triage. And we look at where we can integrate palliative care. So if we look at people in the red group, and red group are where they need immediate treatment because they have a chance to survive, we integrate as much as possible, but we recognize if we look at the balance, saving of life is the priority. Then we have a delayed where people are still quite seriously injured, but treatment can be postponed for a little while. And that's where we can look at pain and symptom relief and at psychosocial support. Where they have minimal injuries, maybe a broken ankle, something sprained, some cuts and bruises, there could be support and symptom relief if there's enough palliative care to go around. But where we need to be there immediately is where that group where survival is not possible because the resources and the care is not available, or because the injuries are just so severe. And that is where we're really looking at focusing our palliative care with limited resources. And technology, we have to learn how to be good at technology, because that gives us the opportunity to provide expert palliative care from outside an area into the humanitarian area. And the interesting thing is that all the major UN agencies do have a department that are looking at innovative technology. So it is so important. We saw it with COVID, we're seeing it with the war in Ukraine, and I think it's something we need to focus more on. How do we as palliative care use the technologies that are available that can do so many different things in the field and that can link those working in the field, the humanitarian response agencies, the country's health agencies with expertise. We can ensure access to palliative care medicines if it needs to cross borders, because there is legislation that governments can use in acute emergencies to apply for simplified crossing of borders of medicines that are internationally controlled substances. So things are sort of there in place. It's how we use it and how we motivate and how we advocate. This is an excellent paper that I've actually sent through for all of you on aid when there is nothing left to offer. And it's an excellent research paper. It took place across 3 countries, and it looked at the justification as a moral obligation and how we integrate palliative care, which is what we're trying to do, how it needs to be contextualized to the crisis, to where it is, what is happening, what are the resources. It looked at the situatedness of dying, looking at social and cultural and belief systems that are important there, and how we provide holistic care, not just the physical care, but what is so often needed, the emotional and spiritual care. And as I've said, that I have provided that paper, looking at how all of these different disasters lead to one another, and not thinking we specialize in one type. We need to be able to look at all of these different types of emergencies. So slowly things are happening. The Sphere project is the Sphere handbook is the humanitarian handbook that everybody uses. And in 2018, we got a standard into it, which was the beginning. We got something into the organization on migration with a community-based palliative care program, and MSF has started integrating it into their programs for the first time. And the Sphere handbook is so important. We were so excited when this got into Sphere because it looks at every aspect of humanitarianism. And here it looked with palliative care at guidelines, including for triage, referral systems, care plans, access to medications, how we support families, communities, and social support, the so often forgotten essential spiritual support and burial practices. And even though it's just a very simple standard, in words, it actually covered all of these things. It looked at provision, community-based care, training of healthcare workers, and the provision of essential medicine and equipment. And of course, we know this, the Lancet Commission on Pain Relief and Palliative Care, this is the essential package of palliative care medications. These are just some of the resources that are available on free to download on the Palchase website. And these were very important publications that came out in 2019, the Field Manual, and Oxford University Press allowed us to provide it free of charge, and the WHO guide. We have briefing notes that you can find on globalpalliativecare.org that came out with the 4 global organizations working together in the COVID crisis. Education is available. There's an ECHO course that is presented at least 2 to 3 times a year now, which is for humanitarian health responders to learn how to provide palliative care in humanitarian crises. We have the first international standard for pediatric palliative care for children that came out as part of the new GOPACS global overview for pediatric palliative care standards from the Maritza Foundation. And recognizing that together we are a global community. It's not just what's happening in one place that gets support. We as a global community can support. And when the crisis began in Ukraine, because we had so many interactions with Ukraine, because of their development of children's palliative care across the country, we brought out the statement and we recognized that palliative care, especially for children, it's not a priority in humanitarian crisis. So we as a global community said, we will take responsibility to do all we can to support our colleagues and to protect these vulnerable children. And a lot has happened internally across borders and with supply of resources that we are still working with. And we made this promise: you are not alone, we stand with you, and we will not forget you. And so these are just some more of the resources for you. What is lacking? Well, we need to recognize we're educating the humanitarian groups. We need to learn from the humanitarian responders. There is so much we can learn about doing things quicker, doing things better, making better use of resources. Every country and every region needs a plan. How do we get people across borders? How do we reach people inside the country? How do we move patients around? And we need to do much, much more on psychosocial and spiritual response to trauma and loss. And as the Elizabeth Kubler-Ross Foundation, we have a fellowship going in South Asia that has 9 fellows across 7 countries. And we're focusing on psychosocial and the spiritual response to trauma and loss, especially in humanitarian settings. And just again to say, we don't get it into our country systems, we're not going to get it into the humanitarian crises. And just a quote to end from, again, from a letter to, in a commentary to the Lancet: suffering in illness and dying reminds us of the universal truth of our mortality and humanity. Palliative care and humanitarianism is rooted in the recognition of our common suffering in illness and dying, a compassionate response to suffering, and our shared humanity. So thank you, and I'm also very happy to answer any questions at the end or via email.
Thank you, Joan. I think we will now move on to Dr. Farzana Khan, who will be talking about humanitarian crisis and South Asian realities. Dr. Farzana Khan, it's over to you.
Yeah, thank you very much. Hi, everyone. Greetings from Bangladesh. And so I'm a huge apologies at first because I cannot open my video, because I tried to open my video and I was disconnected because the connection is really poor today. So I'm really sorry for that. And many thanks to Professor Rajagopal sir and all of the Global Fellowship team for inviting me and make me part of this process. And special thanks to Dr. Smith and Joan Marston for creating this base so that I don't have to explain all these things. The base has already happened. So I have to share my screen. I'm doing that. So could you see my screen?
Yes, yes.
Okay,
We can see the slides.
Thank you. So I just want to start with some basic facts about South Asia. And you know that South Asia includes 8 countries: Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, Sri Lanka, and Afghanistan. So nearly this region has got nearly 1.8 billion people. And every country has its own unique challenges. So, but there are some common realities that affect the entire region. And you know those things. These are, number 1 is overpopulation and poverty, and inequalities exist in every sector of our life, and natural disasters, political instability, health challenges, and climate change. So here are some stats, although you have seen lots of stats about humanitarian crisis, but you can see that UN High Commissioner in 2020 that 82.4 million refugees were displaced out of their homes by force, by conflict or other persecution. So it takes only 2 seconds for a person to lose their home. So 86% of these countries that host the refugees are in the low and middle income countries. And of course, in South Asia, a major portion of these refugees are hosting by South Asia. And these countries have their own developmental challenges, as I said earlier. And so they really complicate the problem further. And of all the countries, we look here, only one country is from high income country, and that is Germany. All other countries are low income country. So humanitarian crisis can happen in different modes, as Joan has already beautifully described. I'm not going to talk about on this. So only two pictures, recent pictures from South Asia. One is 2015 earthquake in Nepal, and in 2022 there was a huge flood in Sylhet, Bangladesh. So I have. So consequences of crisis have already discussed. I'm not trying to repeating all these things because Joan and Dr. Smith has beautifully elaborated all these things. There happens extensive loss of life and sufferings, and mainly the poor, displaced, and females and children suffer from this crisis. So South Asian realities, as I have already told you, the consequences are not a secret. They are very known and known to each of us who are present today. And we are listening to this fellowship program. We know that in South Asia, the realities are really open. But what we are doing and what we can do would be our next step. And I will share with you some of that. So we know that palliative care is essential in healthcare, which is included in the universal health coverage. And this is also a key component to achieve the sustainable developmental goals by 2030. So when we see these pictures, as we have already seen with the other two experts, that these are really common pictures. If you want to see these pictures, you can just click once and you find thousands of pictures like this. But these are realities, and we know that to combat these sufferings, we need palliative care, and palliative care is essential in emergencies. Palliative care is not a luxury, because life cycles continue whenever any emergency happens in a humanitarian area. And life-limiting illnesses become even more severe. Suffering is intensified. Whoever have some previous sufferings, those are really intensified by these humanitarian crises. And it becomes complex. When you have complex health problems or other problems, people think nothing can be done. But there are many things to be done, and we can give back to the suffering people the value, dignity, and control in case of emergency through palliative care. Let us look at a case study in Rohingya refugee camps in Cox's Bazar, where I used to work with one organization, Muslim Crime Research Foundation. So this Rohingya refugee camps is one of the fastest growing and largest refugee camps in the world. More than 1 million people were living in 34 camps in 2017. where a military conflict led more than 1 million people to come to Cox's Bazar in Bangladesh in 2017. Hundreds of NGOs were providing health care at that time. However, palliative care was absent in the camps. Then FKRF, a non-profit that I have said, that used to support internally displaced people in urban slums before the Rohingya refugee crisis through community palliative care services, included refugees in their activities. So I have included this photo to remind the protracted nature of the forced development. This photo was taken 44 years back when hundreds of thousands of Rohingya people had crossed the border to Bangladesh following a spate of torture in Myanmar in 1978. So we did a survey for situation analysis and found that 73% of patients with incurable diseases did not receive adequate treatment for pain, and 68% could not afford medicines. I remember Mrs. Nurbanu, a 50-year-old female with neck cancer with severe pain and a huge foul-smelling discharging wound. She could not sleep or lay over bed due to pain. To control pain, morphine was needed, but not available around camps. So I had to buy tablet morphine from Dhaka and carry that to the camps. And unfortunately, till now, the situation is almost same as before. Till today, there is no evidence that morphine tablets have been used for abuse in Bangladesh, yet it is not available and accessible at any part of the country other than the capital city, Dhaka. So people suffer terribly. This is Mojibur, a 10-year-old Rohingya boy living in Cox's Bazar refugee camp. In early December 2017, I went to a field hospital where one of our field patients was undergoing a breast cancer surgery. The hospital team was elated, having a palliative care physician over there. They were in a difficult position with this boy, just diagnosed with osteosarcoma, for whom they didn't have any surgical option. They requested me to provide home care to this boy, although I choked as I was totally uncertain about how I was going to help this little boy. Next day, we went to their tent. He lived with his mother and two little sisters. His father was missing. The neighbors told me that Mojibur and his mother cried whole of the last night. I asked Mojibur, why did you cry? He answered, I heard doctors telling my mother that I'm going to die soon. His mother recalled, while fleeing from Myanmar, people told me to kill my son with poison because his disease is not going to be cured. So I examined the boy. He was in severe pain, could not move, walk, and needed constant care by somebody else for the last 6 months. So we started pain treatment. Then a miracle happened. After 10 days of pain treatment, Mojibur started limping. And after 2 months of pain treatment, Mojibur could walk pain-free, play with his football, and even smile a little. In the past, Mojibur was a healthy, football-loving boy. His nickname was Bhusha. Bhusha is the Rohingya word, meaning buffalo. So these words, spoken by Martin Luther King Jr., carry a powerful message about perseverance in the face of disappointment. It is important to acknowledge that setbacks and failures are a natural part of life. However, it is crucial to never lose our belief that we can achieve our goals and dreams, even when we're faced with difficult circumstances. Actually, finite disappointments are temporary setbacks that can be overcome with perseverance. The stories I have shared provide evidence that this humanitarian setting should be a place to teach health workers who had no previous education and training in palliative care. Therefore, we should not let temporary setbacks defeat us, but instead hold on to the hope that we can rise above our challenges and accomplish our aspirations. We made health partnerships with local NGOs and global leaders from across the world. I kindly remember that Joan Marston was with us from the very start of our project. So, to ensure quality of care, we organized training for community health workers. Within just 2 months, we reached 1,500 patients with life-threatening or life-limiting diseases. Every story was unique. Interestingly, this started to change the health providers' mindsets. Bedridden paralyzed patients could get physiotherapy at home, or elderly patients got visits by palliative care assistants at home. This is a quote from a nurse. Before, I used to think only about my duty and myself. Palliative care has changed me. Now I think if I cannot attend duty, even in lockdown, my patients will suffer. I would call my patients at home to know how they are doing. Palliative care has increased my love for humanity. Through advocacy, our aim was to make more connection, to influence and support incurable patients' voices to be heard. COVID-19 crisis was a wake-up call to rethink, to give emphasis on palliative care for making a strong public health for all. Through Cox's Bazar health sector, we developed COVID-19 guidelines for hospital and home services in camps. These are a few published and one accepted for publication in academic journals regarding our research in Rohingya camps. So there is an urgent need to integrate palliative care into humanitarian work. We recognize the long list of conflict and humanitarian emergencies, to name a few: Ethiopia, Mozambique, Syria, and others. Serious health-related sufferings are everywhere. The solution is the acceptance of the need for and the value of palliative care by humanitarian agencies, by media, and by national governments. There needs to be support to enable civil society to deliver this need and to have the space to feedback. Solutions are about creating circles of communication and action, as my previous two expert speakers have mentioned and emphasized that. So in mid-1940s, while approaching the end of the World War II, Winston Churchill was working to form United Nations. At that time, he famously said, "Never let a good crisis go to waste." The COVID-19 crisis was a wake-up call to rethink, to give emphasis on palliative care for making a strong public health for all. Actually, we tried to do so. A new era has been started from January 2020. International Organization for Migration, an UN organization, has been providing palliative care in Rohingya camps. So we can see that even in a viral pandemic, a sustainable humanitarian palliative care service can be established, not only for patients who would survive acute injuries, but to respect people who are already at the end of their lives and give dignity to help them die peacefully. I would like to end my talk with a quote from Professor Liz Grant, who is from Edinburgh Future Institute and Global Health Academy of University of Edinburgh. The quality signature of a nation is how it cares for those entering and for those leaving this world. When this is right, all care will come right. There is no doubt that this is also true for humanitarian situations. Thank you.
Thank you, Dr. Farzana Khan. Now I would like to open the session for discussion. So, Anybody would like to ask anything to any of our faculties?
Hello, sir. Sir, it's actually wonderful to see the components of public health, especially the climate crisis, how we address how we keep up the health systems, the crisis of the humanitarian, during the humanitarian crisis like disasters and any other like wars. So it's really interesting to see the integration of palliative care with the humanitarian into the humanitarian crisis. So being from public health background, so it's very interesting to see the topics like this. So it's great to learn this kind of integration into the public health. Thank you.
Sir, these topics are really new to us. These concepts are also new to us. We have not witnessed, I think at least I have not witnessed such crisis and all. So how to be prepared for this is in India, are there any workshops or trainings which is going on regularly?
Could I just maybe comment? Sorry, is that all right?
No, waiting for you.
Okay, thanks. I think if you attend our next PalChase webinar, that is an issue we're going to be looking at. And living in South Africa and having seen what has been happening around the world, I'm now working with different groups in South Africa to say we have to have a humanitarian palliative care group that looks at not only a national program, what to do, how we can move patients, how we can help and support, and what we have to have in place. But I'm also trying to challenge the African Palliative Care Association, which is our regional group, to look at a cross-Africa plan. So I think to me, the idea is it's important to have a plan.
Yeah, I understand that it's important to have a plan. Thank you.
I think we should include this topic in the fellowship in more detail as to how to handle humanitarian crisis, because increasingly India is going to witness a lot of these kind of things like floods. Like Kerala had the flood and we didn't know what to do. Absolutely, we were clueless at the time because we never had that kind of flood at that scale. And people learn from their mistakes and of course the shortcomings, but it was too late at the time. A lot of people suffered. So if we can be prepared next time, that'll be a great help. And if we can contribute from our side, that'll be a great thing. But we need the tools and we need the knowledge to do that. So if such topics can be included in detail in our fellowships in further courses, it'll be a great help.
Sunil, can I say something, Dr. Biju, Punita, Kavin, thank you. And Richard, I mean, I know how busy a person you are. It's amazing that you gave us this hour and a half. And it was important for us to wake up. We pretend that these demands do not exist. They are there. Now, we already, Biju mentioned the floods in Kerala. Punita, you are lucky. You have been lucky so far. But it's unlikely that that kind of luck will hold for a whole lifetime. The major lesson that we will take from these three absolutely fabulous presentations is that the climate change is a reality. It is already affecting us. It is going to affect us more. The kind of response that Joan and Farzana have already made in the face of crisis is a call for us. It need not, Punita, it need not necessarily be a crisis that affects the whole country. When there is a bus crash in your neighborhood, when there is a train accident, in our countries particularly, these things happen more because of our poor precautions. What we currently do mostly is to sit back in our comfortable offices and let somebody else handle the problems. But if we are accepting the responsibility to treat suffering, isn't that where we are needed most? We have been talking about this a lot. If tomorrow there is such an event somewhere in our vicinity, Sunil, Amrita, everybody else, I hope we all will have an action plan ready. Punita, that question that you asked was important. You have been lucky, but we need to be ready. Now, I'll stop there by requesting these experts who have lived experiences about guiding us towards an action plan. That has to be at the microscopic level in our own palliative care services, being ready to handle something if there is something in the neighborhood. At the macro level also, maybe encouraging participation of the community, not only in climate action, but also in having an action plan for humanitarian crisis. If we do not take it to that kind of discussion, maybe awareness is something that fades from memory. Yes, Shravani, COVID, we have seen how poorly prepared we were. It was Arundhati Roy who wrote, the pandemic was a portal. It could open a door, or that portal could be open to pragmatic action, or we can pretend that nothing happened and wait for the next crisis to come. Thank you.
Hello, sir. So adding to that, even Palliative India keeps on training a lot of doctors and other healthcare providers. Is there any possibility that we can form a database of this trained persons or doctors and our medical professionals, so that if there is any crisis in the within our reach or any area around India, so can we mobilize these persons from the area to area? If we can having the mapping of these persons, so that we can, if there is happening in something in Gujarat, we can mobilize those who are interested. We can be mobilized then and there. It can be made into a separate program under Palliative India. Maybe if there is any feasibility. Thank you.
Sunil, Kavain has challenged us to do something pragmatic, create an interest group, something like that.
Yes, sir. Can I ask something?
Yes. Sunil, let Sunil organize his thoughts.
Yes, sir. Sir, it's a totally new concept for us to know that palliative care has role during emergency or crisis situation also, because it has been set in our mind that it's for chronic diseases and all. So it's good to know that. But I want to know that how it is different from emergency medical services, and what is the difference between palliative care and the emergency medical services? How they work differently, or is it the same during this crisis situation? How is it different from emergency medical services? I want to ask practically how it's done. It's done.
Kushbu, I am very tempted to start answering, but then I suddenly realized I should be shutting up and letting the real experts talk. But let me just make one point. You mentioned chronic diseases. Nowhere in the definition of palliative care does it say that palliative care is only for chronic illnesses.
Yes, sir.
Nowhere, not in the WHO definition. No definition includes the word chronic. If there is intense suffering, we should be there.
Suffering.
Okay, sorry, but there is a question there. May I just, sorry, may I try to shut up from this point of time and leave it to the experts to answer the important question? Joan?
Should I try and answer that
Farzana?
one? Yes,
Yes,
it's a
please.
very good question that you do ask. And that is why that our primary work at the moment, our primary focus is getting the emergency response organizations like MSF and Red Cross to integrate it so that everyone who works in those services has at least knowledge and basic skills in palliative care communication. But the emergency groups, their priority is saving lives and preventing further disability. And so palliative care is very low down, and with a lot of them, they say, yes, it's important, but we won't have time, and they don't have the resources. Where palliative care comes along, it's not an either or. We should be integrating it with that emergency response. And Richard, I don't know if you'd like to add something to that.
To be honest, I don't think I have anything very useful to add on that point. The two of you are much better informed than me on this, but I'm afraid I have to go in a minute. And I wonder if I could just make a couple of final points. I mean, in responding to some extent to what Raj said, I mean, those of us that have been working to do all we can to prevent climate change have tended to concentrate on mitigation. What can we do to keep down the increase in temperature? What can we do to keep down the destruction of nature? And we have let adaptation, as it's called, recognizing that these things are already here and we have to change how we work and what we do. We've been much slower at that. I mean, in Britain, we have something called the Climate Change Committee, and there's a mitigation subcommittee and an adaptation committee. And we're bad at mitigation, but we're even worse at adaptation. And a lot of people begin to argue that things are so acute and so urgent that we should really only be doing things that are both adaptation and mitigation. So there are some things that are clearly not. So air conditioning, for example, what might be part of adaptation will make mitigation worse. So I think we have to be, we have to, as Raj was saying, we know there are going to be floods, there's going to be fires, there's going to be migration, there's going to be shortage of food. We have to do all we can to adapt, recognizing these things are going to happen. And that's really, in a way, what the two of you have been talking about. But one of the things I couldn't help noticing, Joan, in your presentation is that where palliative care already exists in some form, you're in a much better shape than if you've got to ship in people from Britain or the US or South Africa. And when I know from the Lancet Commission that some 85% of people in the world don't really have access to palliative care. It seems to me one of the most sensible things to do is to concentrate on building it up wherever you can, rather than flying in a group of people when some crisis happens. And it also leads me to think that I think the future is mainly lies with community and individuals and people and relationships. We're never ever going to have enough doctors, enough palliative care consultants. And I think doing everything you can to build up community power, just as has happened in Kerala, so that when a crisis strikes, as it surely will to everybody everywhere, people are much better equipped to cope. So, I mean, it was marvelous to hear what you're doing, and it's very exciting, and I support it completely. And I couldn't help observe that all three of us seem to have strong connections with Edinburgh. I graduated in Edinburgh, and Liz Grant is a long-standing friend of mine. So I was excited to see the picture of her there. So I'm sorry I have to go, but thank you very much for giving me the opportunity to speak. Bye-bye.
Thank you, Richard, for spending time with us. Thank you very much.
So one recent incident which happened in Kerala, which was a climate disaster, in fact, which was man-made, was the Brahmapuram fire, which spewed out hundreds of thousands of poisonous gas into the atmosphere, which engulfed the whole of the district of Ernakulam and the surrounding areas. A lot of people were affected. Of course, the blame game goes on in the political side. That's a different thing. But I was witness to a lot of people who had respiratory problems, especially the elderly. We've gone to treat a few of them. This was a crisis, but which was man-made, because whichever it is man-made or natural, it is a crisis. In such cases, we have to act fast. We don't have the luxury to plan something and then do. So, do we have such action plans, or should we as palliative doctors get involved and make an action plan of our own? How is it? How can we, kind of face these kind of problems? Because we also are in the midst of it, because we see patients who are suffering, and those people we have to take care. We are called upon the situations into the hospitals as well as in home care. We had to face the situations just last month. I was thinking, how can we help people? What can we do? As Professor Dr. Smith was saying, climate change is something which we all get affected by, and so we all have to contribute. How can we do that? Is it awareness? Is it trying to dispose the waste in a proper way? Can we help? I don't know. Just asking a question.
Farzana and Joan, you have about 953 times more experience with this than anybody else in this whole group. So do please comment. But before leaving you to answer that question, Dr. Jusaraj or Dr. Biju, I'll come back to my point. All the things that you mentioned are important, that the macro level improving awareness is important. But then, unless we demonstrate how something happens, how will people follow that example? So it's also being prepared and demonstrating something, and nobody can teach us better than Joan and Farzana about how they went around doing things.
Farzana, can I leave that to you to answer to start with?
Thank you, Joan. Actually, Joan has already answered that, because someone had a question whether the difference between the emergency medical care in humanitarian camps, the basic principle is same. Saving life doesn't mean that you cannot do something for suffering people. In fact, in humanitarian principle, it is written that you have to do something for the sufferings. But in practice, it is not actually, we don't say much, as Joan has already mentioned this. But I think one of the answer to the doctor, sorry, I forgot her name. So one of the answer is emergency medical care doesn't exist in a huge way in any humanitarian camps. So they have limited capacity, and they just think about their patients with acute injuries, not the patients who has chronic illness or need palliative care. But as palliative care workers, we need to find our way, and we need to give space to our patients. So that's my motto, and I follow that, and I do that. Professor Rajagopal sir know that, because for the last 12 years, I'm telling him to do something, including all the region, because he is in that position. In this Southeast Asia region, Professor Rajagopal sir is in the position who can do all these things in a structured way and in a very constructive way. but I have some complaint against him because he is not initiating this. Thank you,
Farzana,
sir. Yes.
Farzana put me on the spot. Farzana, let me confess, I've not been able to do it effectively in our own place. This is something that is frightfully important. Dr. Gajasraj in between brought up a question. If everybody goes in and starts helping out in a crisis, will we not create a mess? He also asked, can we do it alone? You may still be able to feed a hungry child by yourself, but that kind of microscopic help is all that you will be able to do. And maybe you will get in somebody the way of somebody who is rescuing a whole group of people. We have to form a plan of action. Farzana, I plead guilty. The only effective thing that we think we have been able to do was right at the beginning of the COVID crisis. We worked with a remarkable group called Palliative with Kerala and trained a few thousands of people in the principles of palliative care in COVID-19. But that was something that was possible. You can't possibly do that in a fire or a whole famine. So Farzana, it has been, you mentioned 12 years, maybe in another 120 years, we may be getting around to doing that. So the obvious answer is, don't leave these important things to me, but we will have to leave it to the youth. So many people were so active in the engagement. Sunil, our session is of no use if we do not lead this to some kind of action. And we have that sphere document. We have people like Unni Krishnan and others who are willing to help at the international level. Joan, I am sure, has always been willing to help. Farzana has truckloads of experience. I hope what my generation has not been able to do, you all will do.
Sir, can I make an observation before we all go?
Yes, Dr. Vijay.
Dr. Khushbu was asking how we can integrate palliative care into an emergency medicine or an emergency situation. Actually, I was fortunate enough to be a witness to that because I'm working in a tertiary level hospital. We have the casualty, which has got a lot of trauma coming in. And I was asked to come in to see a patient in the casualty. When I went, the patient had a head injury. The person was young. She was conscious, but she had concussion, and they were planning to take her for a CT scan and things like that, which was the emergency medicine doctor's plan of action. But when I went there, I saw that person was so terrified. She was suffering more of her anguish of anxiety rather than the pain. So I just went there and held her hand and I said, don't worry, we are taking care of you. Everything will be all right. I didn't do anything except just talk to her. And that kind of calmed her down, and that made the decisions of the other doctors so very easy. And she was out of the casualty after about 1.5 hours of observation and treatment. And that is when I thought, yes, we can do palliative work even in emergency situations. So situation varies from patient to patient and situation to situation, but we can do that. The same thing has happened in ICUs also, where doctors have started calling me to the ICUs to see the patients who are, say, for example, in pain, where in ICUs, most of the time patients are suffering in pain and the pain is not mitigated because they are trying to keep the patient alive. So these are different scenarios which are coming out where palliative care can be integrated. And this is what I'm learning every day. But the thing is, we as individuals, and instead of that, as doctor was saying, trying to entrust everything to people like Dr. Rajagopal, we as individuals, we have our own responsibility, and I think we should start taking the initiative to, tell this to our colleagues. They are all our colleagues in other departments. Probably they don't know what palliative care is able to do, except just giving morphine or taking care of people towards the dying stages. So those things have gone. It has come far beyond that, but people don't know that. Even our doctor colleagues don't know that. It's not their fault, but I think it's us who have to start advocacy and talking about this and making ourselves more useful in those situations so that they are convinced that we can do a lot more for the patients and mitigate the suffering of the patients at the end of the day.
Thank you, Dr. Viju. Thank you. Words of wisdom. Absolutely. I know that you must have crossed the time limits by miles and miles. I'm leaving it back to Sunil in a moment after saying making a couple of points. Sri Priya, I hope you will have all the comments. I mean, there have been several volunteers. I hope you will have a record of all these comments. Many of the comments have not been responded to, so that is something that is yet to be done. And as Dr. Biju exhorted, maybe many people here who have the experience should get together and form an initiative. Farzana has so much of experience. Sairu is here. Sairu has had tremendous experience with during that period of floods and maybe during other crises also. So many experienced people are there. By the way, excellent resources are available. Farzana and Joan, I hope you will give the relevant links to the team. The sphere document that Joan mentioned about is an excellent document. Palliative care in humanitarian crisis, about preparing, about going in, I mean, the time gap. All those things are very well described in literature. Excellent work has been done. We just have to follow it up and act on it. Joan, Farzana, you want to tell them about the resources available and any possible. Is the sphere document available online? I don't know. I've seen only the printed document.
You can get it online. If you just Google sphere, you actually get to the document. But the links to the other documents are all on the Palchase website, which is palchase.org. I've just put it into the chat. And join Palchase, come to the webinars. This is a new field. When there are no experts in this. I think Farzana, you'll agree. We're all learning all the time, and it's something that is so essential, because if you just look at the trajectory of humanitarian crises, how more than a quarter of the world is now caught up in a humanitarian setting. You know, when is it going to hit us? It's going to at some stage. So I think it's something we're all learning together. It's a new field. It's based on a lot of old learning, of course, as every field is. But there is so much need for research and development. So I have sent in my presentation, there are links, and I have sent some extra papers as well that will have extra resources and references in them as well.
Sunil?
Dr. Farzana, do you have anything else to say?
At the moment, no. I just thank Rajagopal sir that he has answered honestly, and I have written that just see what you can do. Just you have to call, and you are the one. Action to me means youth. Youth means action, and you are that one. We don't need people of 20 years without doing anything, but we need a person like you. You are the number one young people in the palliative care team globally. Thank you, sir, and thank you everyone for giving us time and listening to us. Thank you so much. Thank you, sir.
Thank you, John and Dr. Farzana for enlightening us with different aspects of humanitarian crisis. And Dr. Richard Smith actually laid a background, and then went on. Joan gave us more idea how to act and what to do, what are the problems, and Farzana actually described how it is done. So that was a wonderful session, and thank you everybody for being with us. Thank you. So over to Sri Priya.
Thank you, everyone. Thank you, Joan. Thank you, Dr. Farzana. I could see the flare going up. Actually, it was not an enlightening session. It was a lightening session. Like I could see the lights already flared up. And I do wish as a common person and as a non-medico that this does work out. People does come together and make plans. Even though there is little time left for us in this planet, I could say. So let us make that life very comfortable for everyone. So with that,
Sri Priya, we were talking about climate change, so there would be storms and lightning always.
so true, sir.
Particularly in South Asia.
Now the drizzles have started. Let us wait for the storm. And let the sounds of lightning and thunder reach every part of the world. That is our wish. So not extending much, this is Sri Priya along with Joan and Dr. Farzana, and then I have a long list of eminent personalities. Dr. Rajapal himself found out time to join us today. Thank you, sir, for that, and thank you everyone for making this session interactive. See you in the next session. Till then, everyone, take care. Bye-bye. Keep spreading happiness.
Thanks, everybody.
Thank you, sir.
Thank you all. Lovely to be with you. Take care.
Thank you, Joan. Thank you, Farzana. Thank you, Sunil. Thank
Good
you,
night.
everybody.
Good night, sir.